Bismillahirrahmanirrahim. Bismillahirrahmanirrahim. Assalamu alaikum, sisters and brothers. Salam. What Migdad failed to mention is that he's only told me yesterday to talk on this subject. So I've had less than 1 day of preparation time. This kind of thing needs a couple of weeks, but anyway, I've done what I think is reasonably good job. So what I want to do is to just outline the principles of the health system we have here and the health system they have in America, just to show what are the differences and what can be the consequences, because I think the way it is going, we are probably heading towards an American type system. Not quite, but nearly there. So we need to be careful of what we are thinking about. Below. Okay. So our presentation today will be looking at general ideas about healthcare funding, insurance basics and healthcare, and then we will move to demographics in OECD countries, NHS founding principles and how the NHS has evolved, and a little bit, couple of thoughts on what Brexit may bring to NHS in this context. Then we go to US healthcare pre-Obama and key Obamacare changes. And then, again, just like Brexit, what Trump's ideas could bring to the United States. So if you look at healthcare funding as a whole, the idea of universal healthcare actually came out in the well-off countries after the Second World War. Part of the motivation was the impending danger of communism. In fact, the whole founding of the welfare state was in large part due to this problem that people may opt for socialism or communism in order to solve the problem which they felt in the 1929 depression and across the war. So part of the welfare state prescription was a national health service. Similarly, in the United States, it was followed after the New Deal, which again was after the Great Depression in 1929 and on. So it's not something which came voluntarily. In fact, there are a lot of new books now coming out saying that the situation we are in, change is only going to come involuntarily or violently. And so we need to be careful how far we can push inequality and so on before things take their own course. Now, the question which obviously is faced when you look at healthcare provision is that should it be private or state? Can the private sector fulfill that function, or is it a state function? Now, this is not a question which is independent. There is a lot of ideology behind it. If you believe that there is no role for the state in government, then you go one way. If you believe there is a role for the state to whichever extent, then you go the other way. As we know, in the United Kingdom, we have opted for significant state control of the healthcare provision. In the United States, they went the other way, minimizing the role of the state. And then whether the provision should be universal or selective, that obviously depends on your philosophy and how far you want to be inclusive. But since this was all part of the birth of the welfare state, an element of universality was inevitable when it was formed after the Second World War. There were, in the NHS especially, there were a number of compromises. So, for example, in the beginning, in order to bring all the relevant and experienced doctors on board, they designed a contract whereby the minimum number of hours consultants had to give to the NHS was 18. After that, they could either give full time or they could practice on their own for the rest of the times to give them a balance. If somebody wanted to make a lot of more money, they could still do it on the private. So there has always been a private component to NHS practice, but in a very pragmatic way. Obviously, as soon as you come to talk about universal healthcare, you're looking at resources. Where are the resources going to come from? Who is going to pay for it? You see, health is one of those things where if you have better health, then you can argue that you will have a better society, more productive society, and so on. But you have to pay upfront for better health. So somebody has to pay. And at that time, when the NHS was born in the welfare state, the idea was that we would have decent levels of taxation, which would then pay for this. And in fact, if you look at key statistics, like just look at life expectancy. Life expectancy in the United Kingdom, I think at the end of the Second World War, if I'm not mistaken, you were looking at about anything between 55 and 60 years of lifespan. Today, we have life expectancy of 80 for men and 84 for women. So we have a good 20 years addition to life expectancy. How much of that is attributable to healthcare or better health is debatable, but quite a lot of it is. In fact, life expectancy in many of the richer countries is going up at that rate, about 3 years or 2 years for every 10 years. And this is a good thing in general, but not so easy for healthcare systems to take care of, right? We will see the demographics soon. Now, in terms of demographics, we're looking at OECD countries only, so we are looking at the rich countries. You have two simultaneous problems. One is that the birth rate is falling. Now, if you look at, for example, Germany, the average number of children per couple is now down to 1.6. You need about 2.2 children per family to replicate the population, right? So when you are down to 1.6, it means the population is going down. The number of young people is going down. Across the OECD countries, the average number of children is under 2, including the Catholic countries. So we are seeing that the whole group as a whole is declining in population terms, right? On the other hand, as we talked, life expectancy is increasing across. So you have a larger number of older people and fewer younger people working who can fund their pensions or healthcare or whatever. So you have a double pressure. So at the moment, you have roughly 4 working people supporting 1 pensioner. By 2030, OECD figures show that that will drop to 2. back of the envelope calculation will show you that will mean doubling your taxation, which is not feasible. Existing rates are also not feasible. So that is the challenge. When funding crisis is quite a big thing, on top of it, the kind of healthcare expected on the NHS is also changing, right? It's not like basic healthcare. Now people, you have all kinds of other additions, and at some stage you have plastic surgery for psychological issues, all kinds of other things, which I'm not saying they are wrong, but they are costly. Old age care, which is different and costly. And all kind of new drugs and technologies, which are also costly. So we will see later the NHS has now designed a structure to see what new drugs can be authorized. Because some of them are very expensive and they do very little. So now you have this very difficult question of saying if a drug costing £500,000 is only going to increase your life expectancy or quality of life for 3 months, is it worth it? Can you deploy that £500,000 to something else better, right? Who will take those decisions and how? These are other questions. And on top of that, now we have, since the financial crisis, the austerity and further resource crunch, right? So we see that there is a lot of pressure. What was working at that time, post-war, is not working now, or cannot work because of these issues. And the United States is facing similar issues, except that its age profile is slightly better because of immigration from Mexico, right, and other countries. If this Trump manages to cut immigration, they're going to have the same problem in 20 years' time, because that's aging will start. So now, in terms of how do you look at healthcare, I think it's important to see if we can understand very briefly the basic principles of insurance here. Insurance clearly relies on the principle that not everybody will suffer the same problem, whether it is car insurance, health insurance, or whatever. A certain proportion of the insured population will suffer certain diseases or whatever. And so if everybody pays small amounts, we could easily pay for it from the insured pool. Yeah, this is a general principle, and it becomes more predictable. So let me give you an example. For example, if you toss a coin, what is the chances of head or tail? If you toss it 20 times, how many heads or tails will you get? 10-10? That's a lottery win. Mukhtar? 20 times? Could be anything. Just not predictable, right? However, if you toss it 1,000,000 times, what will you get? You'll be near 50-50. You'll be approaching the 50-50. Which means that the larger the number you have, you can use the statistical probability of something to price a model. The small number you can't, because the variation and volatility is too big. But the larger number can give you some predictability and you can price it, right? So you can say X numbers will have heart attacks, X numbers will have cancer, this, that. But you can't say that from the Mahfil people, X number will have heart attack or this, because this is too small a population. You need a bigger thing, okay? So once you have that, big numbers, like in the UK, we have the whole country, it becomes quite possible to see what will be the cost of managing this. And since that Second World War and the establishment of the welfare state, we have decided to fund this through the national insurance, which is, of course, an insurance scheme. So it's not saying that everybody will use the health system in the same extent. Some people may just not use it. Some people may use it extensively. But in the scheme of things, we will be fine. So that's where we look at prices and modeling. Now, if you didn't have the state system, or if you allowed private system to interact with the state system, what will the private insurers do? Cherry pick, yeah? Because they say, for example, healthier or whatever way, and leave the more difficult cases to the state. This is what is happening to the NHS at the moment, right? But if you don't allow that, then there is no cherry picking. Then you can mix. You can easily model and sustain it, right? So that's what cherry picking means. And that's where the state versus private debate comes in. And that's where the Americans are slightly different from us. They are more private oriented. And then they have been trying to patch up the question of cherry picking. So also there are a couple of other key issues in the United States. One is that if you have a condition, they just don't want to take you on as a subscriber or a policyholder, full stop. So you're left without anything. But here, there is no option for the NHS to say that since you are already X, Y, Z, we cannot, they have to do as a right, yeah? And these are questions of equity and justice here, right? How far you want to be just and fair in society. So the founding principles of the NHS were obviously equity and justice, which is what the welfare state was about. And also, as I said, it was partly to defray the danger of communism and so on. Now, the decision was that this will be a universal system funded through the state, and it will be free at the point of need. There will be no restrictions and no qualifications at the point of need. I'll be funded by a national insurance scheme. National insurance at the moment now is running at what, about 12.5%, Mustafa? Yeah, 25% actually, because employers and employees. So it's not small, it's quite a big number, and it's not easy to increase that further. And then there was a very limited role for private providers initially. As I said, only consultants who wanted to do a certain number of hours on their own were allowed, but generally there was very little scope for private providers in the NHS as it started. So overall, it worked well for about 50 years. Until the 80s, I think it was working reasonably well. Then we had the beginning of problems. Cost pressures started to increase. The low birth rate, aging population equation started to come in, and so there were other pressures. Tax base of the country started to be eroded because you had companies which were based in tax havens, or companies using all kinds of strategies to minimize tax, which in fact then reduces the tax pot. Yeah? And this is continuing even now with all kinds of other things. There was inflation in the demand of services in the NHS, as I said, kind of things which they started with was very basic and very, very, what you call, urgent. And slowly now it's all kinds of other things. And there is also a lot of discovery of new conditions, things like mental health and so on, which is costly to fund, but we are always coming up against new descriptions of this is what mental health is about, and now some people are saying 60% of us are on mental, so this is not going to be easy to fund. And the welfare state itself is sort of breaking down under this pressure. Right? Now, under the Labour government under Tony Blair, I think they introduced this first kind of private participation in the NHS. So they started to force NHS to offer certain amount or certain percentage of contracts to the private sector. They started to offer the building of hospitals and so on the PPP, private-public partnership schemes, to keep them off the budget. You see, when you're looking at the budget, this doesn't count as expenditure, because your only expenditure is paying when you pay later on. So today, you're done with 15, 20 billion pounds of expenditure, new hospitals and so on, and then. But we are now finding that we are paying through the nose for some of those. Many of the health care trusts are going bankrupt or about to go bankrupt because of the payments they have to make for these facilities. And the private sector has started to cherry pick. In fact, all private providers here, when there is an extreme emergency, they pass the patient back to the NHS. So if you didn't have that, they are not paying for that backstop, right? So, and this is sort of beginning of the process. And because of that, the state is left with the more acute cases. And increasingly, that's going to be the state of the NHS. We have now, I mean, there are some doctors in the audience, I know. We have large number of people just occupying hospital beds because the old age care system does not accommodate them, right? So we are using beds for the purpose for which they are not designed, and we're just clogging up the system from all ends. So this is the problem of the NHS. Now, how to solve that? Is the solution to go to the American system, or to think through back again that we need a proper state provision and maybe an increase in taxation to fund it? There is no other way to fund this thing. So what could Brexit do? I always look at Brexit as what Idi Amin thought of Asians in Uganda, right? He thought that if I throw these people out, all my problem will be solved. But soon he found that no problem is solved, because this is not a solution. Similarly, these Aam Aadmi fellows in Delhi, they also thought that if we just take government and we do this, everything in Delhi will be solved. Now they are finding that it's not that easy to run that place. And so Brexiters, in the same vein, thought that if we just get out of Europe, everything will be solved, and so on. And you remember this propaganda that if we go out of Europe, we will save 350 million pounds a week, which we can put into the NHS, and the NHS problem will be solved, right? Now we are saying that there might be a 50 billion liability to be paid to the EU, because we have made pension commitments, we have made all kinds of other commitments which need to be serviced. So that might lead to a further shrinkage of the state as they go for austerity, which will imply a more involvement of private sector in the NHS. Now, how they will do it, you saw the last one, was it Hunt? Was nearly there, and then he messed it up a little bit, and then it's slowed down. But I think that's the kind of thing which is going to come. And so they will say that 70% of all NHS contracts must be given to the private sector. And that will be the end of what we want to do as a state system. So we're looking at the US type thinking there. So let's see, what is the US system there? The US system has always been a private insurance focused model because they believe that state provision is communism, full stop. Even now, when Trump is saying, I want to repeal it, he said, this Obama made us socialists. We want to get out of this. I want to repeal this Obamacare and get back to where we were, right? So there were two systems there before, Medicare and Medicaid, and let's see what they are. So Medicare is a single-payer national social insurance program administered by the US federal government since 1976, currently using about 30 to 50 private insurance companies across the United States under contract for administration. United States Medicare is funded by payroll tax, premiums, and surtaxes from beneficiaries and general revenue. So this is the bigger part of the thing, right? And even this was introduced by Johnson. And this is also not, it is also considered to be socialist because it is still subsidized to some extent for some people by the state and through the state. On the other hand, the other one is even more. Medicaid is the United States is a social health program for families and individuals with limited resources. So this will be the lower sector of the people who cannot afford those premiums which are paid by the others. Because the others, in the United States, there's a lot of companies which pay the health care bill of their employees. So it's paid by your employer, so that's how it is. Now, as you get this new kind of employment coming in, like Uber and this and that, there is no employer to pay your health care bill, so you will be shifted onto this. However, with these two programs which they had, the problem was that in a country which was saying that we are the richest country in the world, 40 million people had no health care at all. Okay? So, now whether you think that's acceptable or not, that was the situation when Obama came. In fact, even before, when Clinton came, Hillary Clinton was health secretary at that time. She tried her best to change it, but she couldn't. But Obama finally managed to do little bits of changes, not much. So let's see what he has done. So the case for Obamacare was, of course, that universal health care identified with socialism. So you can't talk about state provision of health care. But there were serious gaps in health care provision. And actually, socialism would come if you don't do anything on that. And the Democrats have always been in favor of doing something more. But the Republican administrations have been pulling it back all the time. You can see one of the big battles at the moment is for the appointment of the vacancy on the Supreme Court. Because the Supreme Court will decide whether Obamacare can be repealed or not. And this appointment is very, very critical for the Trump's agenda on this. Okay, Sajad, can we play the smaller one, please? Just a small, very short 4-minute video to see what Obamacare is about.
Hey everybody, it's me, Ben, and today's question is specific to the United States. How does the Affordable Care Act work, and what does it do? Although its full name is the Patient Protection and Affordable Care Act, you've probably heard it just called the Affordable Care Act or Obamacare or the ACA. It's called Obamacare because President Barack Obama signed it into law on March 23, 2010. But what does it actually do? Let's look at the basics. Healthcare in the United States has some serious long-term issues. First, there are millions of uninsured people. Second, people who do have insurance tend to pay more for it than they would in other comparable countries. The ACA aims to fix these issues by making affordable healthcare available to more Americans. I mean, that's a good idea, right? To do this, the Act makes some pretty big changes, but although the Act makes some big changes to insurance, these changes phase in over time instead of happening all at once. A lot of things will also stay the same. For example, if you already have health insurance that you're happy with, you can keep it under this law. And children under the age of 26 can stay on their parents' plan. If you already have Medicaid coverage, then you're going to stay on that too. Or you can if you wish. In fact, many states are expanding Medicaid to cover more people. So now let's talk about what's changing. There are several things. First, there's this thing called the individual mandate. Most Americans will be required to have some form of health insurance. This is a sweeping change for a country with an estimated 30 million uninsured residents. But how do you enforce something like that? By 2014, everyone without health insurance will need to pay a small fee. During that year, for instance, the fee is going to be $95 per adult, $47.50 per child. The maximum a family will pay in 2014 is $285. Now those numbers are over the whole year, not month by month. To make sure that people can find affordable insurance, the ACA creates what are called health insurance marketplaces. These are virtual spaces run by the federal government or by your state where customers can see different plans and prices offered by insurance providers. So ultimately, this might allow you to qualify for lower premiums depending on your income and your family size. And regardless of what kind of insurance you have, insurers will no longer be able to deny or revoke coverage for pre-existing conditions. And women won't have to pay more than men for insurance either. Finally, right? Insurance will also cover preventative care. So this will be stuff like mammograms and checkups and screenings and so on. Then there's the 80-20 rule. Insurers will generally be required to spend at least 80% of the money they get from premiums on, wait for it, actual health care. If your insurer spends too much on overhead, then you're going to receive a rebate. Finally, the laws also require companies to publicly justify rate increases of over 10%, and they are banned from imposing lifetime dollar limits on benefits. This act also affects your employer, whether you work for a large company or a smaller company. A smaller business, one with less than 50 employees, can visit the Small Business Health Options Program, or, get this, SHOP, right? Government loves an acronym, to compare and purchase affordable health plans. Additionally, some of these businesses might be eligible for tax credits if they get coverage through SHOP. The rules are a little bit different for bigger businesses. In 2015, they have to make what's called an employer shared responsibility payment if they don't provide insurance meeting a minimum value standard, or if one of their employees gets a better deal in the individual marketplace. Since states are implementing the act in different ways, it's very important for you to check on the specific plans of your home state. So that's it. If you'd like to learn more specifics about the Affordable Care Act, check out www.healthcare.gov for more information. And hey, while you're online, you can always like this video if you're into liking stuff. If you want to learn more about everything from lightsabers to the speed of light, you can subscribe to our videos. And if you want to see some more videos like right now, and you're just thinking, I want to see some more videos, then we got 3 on the side over here. And we'll see you next time.
Okay, so that's a very, very short and sharp introduction. So actually, Obamacare is called the Patients and Affordable Health Care Act. And this was his main work. So the Patient Protection and Affordable Care Act, often shortened to the Affordable Care Act and nicknamed Obama, is a United States federal statute enacted by the 111th U.S. Congress and signed into law by Barack Obama on the 23rd March 2010. Under the Act, hospitals and primary physicians would transform their practices financially, technologically, and clinically to drive better health outcomes, lower costs, and improve their methods of distribution and accessibility. The Affordable Care Act was designed to increase health insurance quality and affordability, lower the uninsured rate by expanding insurance coverage, and reduce the cost of health care. It introduced mechanisms including mandates, subsidies, and insurance exchanges. The law requires insurers to accept all applicants, cover a specific list of conditions, and charge the same rate regardless of existing conditions or sex. So this is quite a revolutionary change. Obviously, insurance companies which were cherry picking and adjusting their business and, as you said, probably creaming off more than 20% as profits. Now the profits have been limited to 20% sharp, have all been disciplined. In fact, if you look at the progress of Obamacare now, you will see that, and especially now with the Trump coming in, big insurance companies are saying we're just going to stop providing health care. They just want to blackmail Trump into going back into this because their profits have been trimmed and they cannot cherry pick. They have been forced to take on all kinds of patients which they wouldn't otherwise do. This act has already caused a significant reduction in the number and percentage of people without health care insurance, with estimates ranging from 20 to 24 million additional persons covered during 2016. Increases in overall healthcare spending have slowed since the law was implemented, including premium for employer-based insurance plans. The Congressional Budget Office reported in several studies that the ACA would reduce the budget deficit and that repeating it would increase the deficit, or repealing it, sorry. As implementation began, first opponents, then others, and finally the president himself adopted the term Obamacare to refer to the act. Now, the law and its implementation faced challenges in Congress and federal courts and from some state governments, conservative advocacy groups, labor unions, and small business organizations. The United States Supreme Court upheld the constitutionality of ACA's individual mandate as an exercise of Congress's taxing power, found that states cannot be forced to participate in the ACA's Medicaid expansion, and found that the law's subsidies to help individuals pay for health insurance are available in all states, not just in those that have set up state exchanges. Together with the Health Care and Education Reconciliation Act amendment, it represents the U.S. healthcare system's most significant regulatory overhaul and expansions of coverage since the passage of Medicaid and Medicare in 1965. So this is the next wave after those times to bring this on, right? It's very, very major. I mean, I think it would take a couple of years for us to understand the full complexities. I mean, we are leaving the NHS, so we understand it instinctively. But what I looked at it, I said it would take a long time to understand the intricacies of this and how it works. So we want to look at the larger numbers to see what it means. And here they are. You can see that already the number of people who are uninsured goes down, all kinds of other outcomes, and the cost is really not that significant to the American taxpayer as a whole. There is a cost because obviously there is an increased spend. If you want to bring 40 million additional people into the healthcare system, it's not going to be free. Some other figures here you can see. I think we can leave this at the moment out. So, key Obamacare changes. Pre-Obamacare, up to 40 million Americans without any health care. So up to 20 million of these more have to be included. So that means there is more equity, more inclusion. The burden sharing of health care for the United States is more equitable. And it prepares the United States for the coming demographic issues which we face here already in terms of aging population and dropping birth rates. But they have big private sector lobbies. I mean, those 26 insurance companies, they are huge. Can you imagine 26 companies insuring 200 million people, 250 million people for all their healthcare needs? And if you try to trim their profits, then you're looking at huge issues. And obviously, the Republicans are saying that this is introduction of socialism by the back door by Mr. Obama. So post-Obama, accusations of socialism, as I said, mobilization of vested interests, because they know that this is the right window of opportunity to repeal it. I mentioned the battle over the Supreme Court judge, which is very critical. If that guy comes, he will be quite instrumental in upholding any potential repeal. Light regulation and lower tax lobbies also mobilized. The key objective is to repeal Obamacare. And if immigration curbs successful, then demographic challenges will compound. But it will be too late until the United States realize that there is no solution in neoliberalism to these issues. We have to have a state-funded system. Most of Europe has gone that direction, and any successful healthcare system will probably need to look at that. That's my small contribution.
Salawat. We have time for questions from either side, if anyone's got questions.
Thank you. When President Obama introduced this, the nation should have been very happy, and therefore, it's to their benefit anyway, if President Trump wants to do something, is there no opposition to it?
In 2010, indeed, quite a large part of the United States was quite happy, because obviously 20, 30 million more people were going to come into the healthcare system, and potentially more. At that time, I think the House of Representatives was controlled by the Democrats, and the Senate was controlled by the Republicans. Today, both are controlled by the Republicans. And so vested interests in that direction will be quite active. Secondly, as I said, the balance in the Supreme Court is shifting. Now, 3, I think, new judges have been appointed by Republican administrations, which are in favor of this kind of thing. And now the 4th, Obama wanted to appoint him, but this guy frustrated him because he didn't control both houses. And now they are trying to force this present nominee. They are saying that we will force him by what they call the nuclear option, which means not resorting to proper process.
Yeah, that's quite obvious, because President Trump wants to put everything on nuclear and destroy the Middle East and this and that, and at the same time, he's destroying America as well.
Well, that's for Americans to judge. We can only see what will happen.
Because there was something good Obama did, and everybody should be happy, and Trump should be thankful to him as well, rather than destroying this thing. So how can we trust Americans when they don't care about the rest of the world? Because one of the poets in Pakistan said, in UNO, U is for USA, and for the rest of the world, no.
Assalamu alaikum. Thanks for your talk. At the beginning, you mentioned, perhaps rightly, that a lot of the distinction as to whether people opt for a welfare state or opt against it, or opt for something more private is down to ideology. And for me, at least, my understanding of it, a lot of the discussion after that sort of is summarized by that. It's based on ideology. Assuming people are going to stick to their stances, and you get in one camp the people who definitely don't want anything to do with anything that looks like socialism, and on the other hand you get the people who are really invested in the society we live in and don't think that there should be a conflict of interest between different communities and want that welfare state. Assuming they're going to stick to their camps, and no one's going to agree on whether or not and in what form we should have a welfare state, what models, are there any models in the interim which can please sort of both sides, more models which aren't necessarily national community care models, but maybe more based on interest or local communities, or sort of like a scaled down NHS? Does something like that exist? Do any ideas like that exist in either the USA or the UK?
It's very difficult. I mean, this is what Blair wanted to try. Because as I explained, the way insurance works, unless you universalize it, the kind of cherry picking and sub-interest groups will always make a problem, right? Now you're right that there are 2, maybe 3 camps which are adamant on their position, and then everything flows from there. But what increasingly several historians are showing is that in such a situation, change has always come through violence or revolution. So they are saying that unless you want violence or revolution, get your act together and forget your ideology. I don't know if you will or not.
Good summary. It has some connotations. I'm thinking in different terms. If I can be devil's advocate first and say that Obamacare looked after people in real terms of writing down laws. Those 30 or 40 million people, maybe most of them were not particularly citizens or had not paid into the tax system. So I'm now thinking, if you transport that to current situation in England now, is it possible that a simpleton like me would have thought that, yes, we get rid of these immigrants, and it actually, for the short term, it'll allow us to stabilize our act, including the NHS, which is obviously, a layman's terms, it is a solution. So do you think people fell for that?
Okay, to take the first point together from you, these 40 million are US citizens. Obamacare is only applicable to US citizens, right? So those 10, 14, 18 million Mexicans or unregistered, these are out of this. No, so they have no, so there will be 50, 60 million, okay? As for your second part, before you can send the immigrants back home, your systems will collapse because it's run by immigrants. The whole NHS will just collapse. So it's not something, it's just like an Idi Amin kind of thinking, right? But you look at the numbers and you look at the contribution there. So there is a contribution at the top end and the bottom end here, right? The bottom end is these farm workers, that recent, and builders and so on. Top end professionals, especially top heavy in the NHS. So that fantasy will also not fly.
So just wondering what you thought about the theory about that you need to have a relatively homogeneous sort of population for a welfare state to work. So if you look at places like Sweden, where up until I guess recently they've had a very, very sort of ethnically less diverse population than other places as well, like the USA, and it helps them maintain a greater sense of a welfare state. And I wonder if there are examples of actually a welfare state working in very mixed populations. And the second question is, what's the role of the private sector then for the NHS? Is there a role for the private sector in the NHS in your economist's opinion?
So I think the question about homogeneity is quite important and interesting here, right? Yes, clearly, if the whole place was homogeneous, the level of fellow feeling would be higher. So presumably you will be more willing to pay taxes to support your own kind, right? But in an age of globalization, what we have been thinking is that we could create this kind of fellow feeling in terms of the common good and common purpose rather than specific. So homogeneity in the sense you are describing is what we will call xenophobia, right? But a more liberal conception of homogeneity will be people who are benefiting themselves. So for example, one of the new suggestions now is to create something called the universal basic income, yeah? To create a starting point where everybody is level, so you have a buying power for anything, right? That might solve this problem. Going the other route, for a country like the United Kingdom, is just not an option. We cannot exist without global connections. So that's the problem, right? What was the second part, sorry? Whether the private sector has a role. Private sector role. Now, it's often said that, and this is ideological very much, that the private sector brings a better discipline and does this and that, but all the studies I have done is the private sector has just got smart at fleecing the taxpayer, really, and taking as much as they can. So I don't think necessarily, there is a rule and there is a role for more commercial decision making within the voluntary or the national sector. Now this is a very different. Now again, that depends on what kind of motivation you are giving to your managers. Yeah, if you're giving them short-term targets, then obviously private sector is something which will deliver and then don't care about the long term. But this is a long-term business. Any long-term business like health and education has to be undertaken by the state primarily.
Just an FYI for everyone, we have the coordinator of Basic Income UK, who is on the board of the Unconditional Basic Income in Europe, coming in July. So look forward to that, inshallah. What's that?
I suppose it's too complex a subject because it's got too many moving parts, right? So, but to dumb it down a little bit, right, to kind of in some big chunks. Firstly, I think that as long as I can remember, this crisis is looming, right? At some point in time it'll arrive, but it's looming since I graduated, so that's fine. So, but there seem to be two sides to this equation. One is a money side question, so resources. And, you know, in a sense, whether the state funds it through taxation or people pay it through insurance, there's an absolute amount of money that goes into the system. And the fundamental problem is that there isn't enough money for an environment where demand is just growing. And so you can't stop demand. You can stop demand by not providing service. Or you can let people die, as in other countries. But it seems to me that we can't escape the fact that actually, despite what we say about industrialized countries, we simply don't have the money to provide the level of provision that we feel that we want. But that's not unusual. I mean, if you take pensions, for example, everybody wants a big pension, but they can't have it. So you end up with a certain amount. I think for everybody else, the question has to become is, do we want to supplement the healthcare provision that we as individuals want? And so are we forced to then enter into private care insurance? Or do we just say, well, I'm going to live in a pension which doesn't fit my lifestyle? I mean, is that the answer? So I think fundamentally you're left with that, unless you see another intersection that's going to come.
So you're quite right that as I tried to say, that the resource pressure is overlaying all this discussion, right? There is finite resources and potentially growing demand because of demographics, because of the change in the kind of healthcare provided and so on, yeah? Now, the question is that how are you going to distribute that burden between people who can afford and people who can't? This is the question, basic at the end, yeah? Where the Americans are coming from the other end, they are saying fully private, and then we patch up the people who can't afford with the basic Medicaid or whatever, right? We are coming with another solution here saying full access, and then you can top it up. But then when you top it up, one would want to see that they pay the actual cost of the service rather than just marginal cost, which means then they have a resource demand from the main center. These are the kind of discussions we need to get into. But you're right, there is a resource crunch. But at the end of it, the discussion is about equity. How far, and that's where Khalil's idea comes in, whether if we were homogeneous, we would be more willing to be equitable. I don't know.
So just to come back on that, because I know there's some work elsewhere, but so you see, as a community, right, we cannot escape the question of, our community, however many layers of the community onion you want to go out, right, is that we cannot escape the question of how we should fund our future, right, in terms of pensions, healthcare, education. We can leave it all to the state and say we deserve it, right? Or we can intervene in our own future. So we can't escape that.
So I think there's a twin-track approach here. Yeah? One is that we work as much as we can to enable the state to do the best, right? So that's a constant. In the meantime, we plug holes with our own designs, yeah? And own sort of contributions or whatever, because that one is like making all the state schools the best in the country, right? It's not going to happen quite soon. So in certain areas, you might need to plug that hole. Now, ideologically, this is not very satisfying, right? You're saying one thing and doing something else. But if you want to be pragmatic, yes.
Because the thing that comes to mind, of course, is which is the one that emotionally touches everybody, is that when your elderly parent has to be looked after, you are going to intervene.
Yes.
Right?
Exactly. Or when your child is going to school, you will make a decision, right?
Thank you very much. I know there are a couple more questions, but we're going to end there. Iqbal calls around, so he can ask. You can answer. You can ask some questions to him afterwards if you'd like. Just a few announcements. This Sunday we have the monthly personalities, the life of Imam Ali alayhi salam, with the main talk from